Good afternoon. I'm Alan Unell, and this series of videos is Healthcare Reform Advocacy, where we address problems in the healthcare system and come up with actions that we can all take to make the system better for all of us. This is a follow-on video regarding Medicare. So first, welcome to Medicare season. It's October 15th to December 7th, 2023. Those of us who are Medicare subscribers are busy evaluating plans and trying to decide what to do. I received a good comment on last week's column on Medicare, and I want to share it with you. Here it is. If you can, go with a Medigap policy in traditional Medicare, not Medicare Advantage. Start with the best gap insurance you can. Medicare Advantage banks on having enough healthy participants to offset expensive, unhealthy patients. And guess what? As you age, your health isn't going to get better. In my area, Medicare Advantage has been getting publicity for denying claims, even for in-network care. Remember, Medicare Advantage is private insurance. It's not public insurance. Another reason to avoid Medicare Advantage is that once you're in, it's hard to switch out. You have to show that you do not have a number of pre-existing conditions before a private Medigap insurer will take you on. So get the best gap policy you can at the beginning and have a good day with it. I will recommend, if you're going to go that way with traditional Medicare and a Medigap policy, get a drug plan of some sort, because if you wind up in a situation where you have huge drug bills, you want somebody to be picking up those bills. I think I mentioned in one of the videos, a friend of mine has a number of serious health issues. He's feeling good, and so that's good. But his drug bills are like $15,000 a month, and he doesn't have to pay anywhere near that. So, okay. I will add that this year we were looking at gap plans in my neighborhood, my wife and I, and what we found was that a lot of them were setting rates by the neighborhood you're in, not by your health. However, the reader was right, or the person who contacted me. If you have a number of pre-existing conditions, they could jack up your price or just choose not to insure you. Okay, let's talk about ACO REACH. What the heck is that? I received a request from a reader of our daily newsletter asking if I could clarify ACO REACH. So now, before I go too far, let me say that down below in the description section is going to be a link to a Healthcare Advocacy Newsletter that has the text for today's whole video and all of the links and all of the recommended actions. They're all in there. Okay, so she wanted to know, what's ACO REACH, what's its relationship to traditional Medicare and Medicare Advantage? First, the acronym. Accountable Care Organization, that's the ACO, realizing equity, access, and community health. That's the REACH. Okay, well, let's talk about it. First, I want to give a big shout out thank you to Physicians for a National Health Program and for their resources on ACO REACH. And a lot of the links that are in the newsletter that you should avail yourself of are from their site. So first, let's talk about Traditional Medicare, TM. It provides beneficiaries the free choice of any doctor or hospital, and it reimburses providers at a set rate for their services. Because of its simplicity, the program spends 98% of its funds on patient care and only 2% on administration of claims. Remember, hospitalization, Part A, mostly covered without monthly payment. Part B, medical, requires a monthly payment. Drug plans and gap plans are purchased separately. Medicare is largely an old-style 80-20 coinsurance where you pay the 20% and the insurer, Medicare, pays the 80%. Okay, got that one. Now let's talk about Medicare Advantage. Medicare Advantage is run by commercial insurers. They may be for-profit or not-for-profit, but they run those private programs. The government, Medicare, it's actually the Center for Medicare and Medicaid Services, a division of Health and Human Services, pays Medicare Advantage insurers via what's called capitation, which is a lump sum for every person they have enrolled. The Medicare Advantage insurers must spend 85% of what they get on patient care, keeping the other 15% as overhead and profit. Taxpayers spend about $321 more per year to cover a senior through Medicare Advantage than they do compared to traditional Medicare. Did you know that? Annual gross profit margins for Medicare Advantage plans are about an extra $1,608 per enrollee between 2016 and 2018. You have to remember that you make more money by charging more, upcoding the patients, and providing fewer service denials. Now, due to fraudulent upcoding, what that is, that's where a Medicare Advantage insurer will report one of their enrollees as far sicker than they really are, and then the government actually increases the amount of capitation to way over $1,000 a month for them. It turns out that people in Medicare Advantage are 19% higher risk levels than in traditional Medicare, causing Medicare to overpay the Medicare Advantage insurers by more than $106 billion between 2010 and 2019. I want to tell you that studies have been done where they took people who went from traditional Medicare and into Medicare Advantage and then compared their risk scores, and oh my God, you wouldn't believe how sick they got just by changing insurance. Okay. We've seen that the top Medicare Advantage providers are pretty much all under Department of Justice criminal investigation for this kind of fraud. And it's not just that the fraud exists, it's that when the government tells them that they've detected the fraud, they don't go back and fix it. And so that's when they get into trouble. And I got to tell you, this kind of trouble, it runs into the billions of dollars for each one. It is incredible. Anyway, so that's just profit, and this occurs at both for-profit and not-for-profit Medicare Advantage insurers. So there's billions of dollars that are just wasted in this kind of fraud. Let's talk about direct contracting. This was a pilot program that was developed in the Trump administration, amazingly enough, by a school roommate of Eric Trump's, to further privatize traditional Medicare. So they've privatized about half of it into Medicare Advantage. Now they want to get the rest of it into private hands, and that's what this scheme was. It uses a lot of the same elements of Medicare Advantage, and there's a link down below in the fact sheet. You should take a look at it. Instead of paying private providers directly for care, Medicare will give a capitation payment to middlemen called direct contracting entities, or DCEs. They are allowed to keep what they don't pay in health services. This is a really dangerous incentive to restrict the medical care that seniors get that previously didn't exist in traditional Medicare. Remember, in traditional Medicare, 98% of the money goes to claims. In Medicare Advantage, 85% is supposed to go to take care of sick people. Here, it's way more that they get to keep. I believe it's about 40%. A majority of beneficiaries choose traditional Medicare over Medicare Advantage because they have the free choice of providers and the power to manage their own care. However, millions of beneficiaries who actively choose traditional Medicare were being automatically enrolled into third-party direct contracting elements without their knowledge or consent. How the hell did they do that? Well, let's look at the business model. DCEs are incentivized to increase capitation by upcoding the diagnosis, we saw what that was with Medicare Advantage, and decrease the expenses by spending as little as possible on care. However, opportunity for profit is much higher in DC. Remember, while Medicare Advantage insurers have to spend 85% of Medicare payments on patient care, DCEs can spend as little as 60% of their revenue, keeping 40% as profit and overhead. If you were going to invest, you'll make a killing with this. Okay, but it's not good for the patients. Virtually any type of a company can be a DCE, including commercial insurers, venture capital investors, even dialysis centers. excuse me, applicants are approved by CMS without input from Congress. The DC pilot officially launched in April of 2021 with 53 DCEs in 38 states, and they enrolled 344,000 beneficiaries. A majority, 28 of the 2021 cohort of DCEs, were controlled by investors. Of the investor-owned DCEs, 6 of them were owned by 4 different Medicare Advantage insurers. CMS paid the DCEs about $3.6 billion. There's a huge impact on patient choice, and here's how it works. Medicare auto-aligns beneficiaries in traditional Medicare into a DCE based on their relationship with a DCE-affiliated primary care provider. To do this, Medicare automatically searches 2 years of beneficiary claims without the knowledge or consent of the beneficiary, the patient, for any recent encounters they've had with a DCE-affiliated provider. You happen to go to one doctor that happens to be in a DCE. They are then automatically assigned to that DCE. If a senior is auto-aligned to a DCE, the only way to remove yourself, excuse me, is to change primary care providers. DCE-aligned patients are allowed to get medical care outside of their DCE network, and out-of-network providers are then paid directly by Medicare at Medicare contracted rates, and CMS reconciles those costs back to the DCE. Therefore, the DCE has a financial incentive to steer patients to specialists in their network, where the DCE has direct influence over the payment model. If the patient now chooses out-of-network providers, then traditional Medicare takes over. But this is really complicated, and it's done without the patient's knowledge. Okay, direct contracting becomes REACH. You can hear how people losing access to traditional Medicare would be upset, and they were. And there was a huge public outcry that caused the Department of Health and Human Services to stop the DCE experiment. In January of 2022, 54 members of Congress sent a letter to Secretary Xavier Becerra demanding an end to the DC program. And in early February, Senator Elizabeth Warren actually spoke out against the program in the Senate. And if you look in the newsletter that'll be below, there's a link to her speech there. Anyway, in response to this growing opposition, HHS, the Center for Medicare and Medicaid Services, both CMS is a part of HHS, announced in late February of 2022 that it's canceling DC at the end of 2022. But they're replacing it with a nearly identical privatization program called ACO REACH, and it went live on January 1st of 2023. Providers have to demonstrate quality care, but it's more like students grading their own exams. Typically, if you let students do that, they get A's. Okay, so what happens? They have to submit a health equity plan based on the fill-in-the-blank worksheet, and guess what? It's not measurable or enforceable. And in the newsletter, there's a link to that worksheet. If you have nothing to do, you can laugh at it. Despite the rebranding, ACO REACH retains all the most dangerous elements of direct contracting. Investor-owned middlemen who can pocket now up to 40% of Medicare payments as profit and overhead. Automatic enrollment of beneficiaries who must change providers to opt out. Opportunities to increase profit by upcoding and restricting care. The potential to expand privatization to all of traditional Medicare, which is kind of what they're really after. As one industry analyst put it, the ACO REACH rebranding is a public relations exercise that should not tangibly impact the for-profit entities currently participating in the model. So no change to those that are already making a killing. I include a link to the government's ACO REACH webpage. If you sign up there, you'll get regular emails on the program. Okay, we need to take action. There is a link in the newsletter so you can sign PNHP, Physicians for a National Health Program's organizational letter. Organizations can sign on the letter protesting the implementation of ACO REACH. If you work at a medical organization or you're part of a nonprofit or some other activist group, think about getting your group to sign on. It would be good. You individually can sign the PNHP petition to Congress, and I'll have that link down below. It asks them to halt the program. Now, individually, there's more you can do, and here's another action you can take. You can ask your senators and congressional representatives to send a letter to Secretary Xavier Becerra at HHS and to Laquita Brooks LaSure, who is the head of CMS, who manages ACO, and ask them to stop it. You can call or email them, and in the newsletter there's a link to how you can get in touch with your senators or representatives. Or on your cell phone, you can send a text message to 50409, and the text, what you text is sign, SIGN, PPQ, STW, and I'll read you the email that you're going to send. I'm your constituent, and I'm appalled that the Department of Health and Human Services and the Center for Medicare and Medicaid Services are operating the ACO REACH program. Here's a brief summary of this Trump-era giveaway to private companies. Traditional Medicare recipients are signed up without their knowledge into medical networks and have to change doctors to go back to traditional Medicare. ACO REACH middlemen get to keep 40% of the money the government gives them to care for patients as profit. There is a huge incentive to deny service. There's also an incentive to list patients as sicker than they are in order to get larger capitation fees from the government. I want you, the congressperson and the senators, to send letters to Xavier Becerra, Secretary of the Department of Health and Human Services, and to Laquita Brooks LaSure, head of CMS, and tell them that this is a huge giveaway of public funds. It takes choice away from seniors, and like Medicare Advantage, is set up to be rife with fraud. Let seniors have the Medicare that they were promised. And I include the emails for both Xavier Becerra and Laquita Brooks. And we, of course, end the email by saying thank you. Okay, newsletter will be down below. I'm going to put the actions in there separately so you can do them. Like, subscribe, share this. You can also subscribe to Healthcare Advocacy Newsletter and receive these messages every day in your inbox. Have a good evening.